Hi guys, welcome to Mastermed Academy. I hope you guys are doing great today. If you are new to my channel, then please hit the subscribe button below and press the bell icon to receive future updates on our new and upcoming videos. And don't forget to follow us on Instagram. So today we're going to be talking about amyloidosis, its types, causes, and the treatment. Now, what is amyloidosis? Amyloidosis, if you want to remember in just one sentence, it's a misfolded extracellular protein deposit that are prone to aggregate and form insoluble fibrils. This is just one sentence definition. Now you must be wondering, what is a fibril? Now fibril is basically a polypeptide. It's a protein. So it's a polypeptide that are intertwined, right? And they form a beta pleated conformational state. From biochemistry, you guys must be remembering that we have two types of protein foldings. We have alpha and beta, and most of the protein, the majority of the proteins in our body are all alpha, right? And we don't have much of the beta pleated shape of the protein, right? Now, all amyloid proteins are morphologically similar, right? But their biochemical composition is a little bit different, right? So you must know that amyloid are basically proteins that are really hard to get rid of, right? They don't undergo the normal protein degradation that is done in our body, right? So it's a really waste protein. It's a useless protein. It is just lying around and it is causing damage to, and we will need to see what kind of damage does the amyloid cause and exactly how can we treat it. Now you need to remember that amyloid have 95% polypeptides and 5% glycoproteins. Normally the proteins that we have in our body have alpha pleated sheet conformation or alpha helical structure, right? So majority of proteins have alpha helical structure. You have to remember that. Now this is a structure of a normal protein, and you can clearly see that we have an alpha helix here, right? And we have a beta pleated sheet. Normal proteins have alpha helix and the amyloids have beta pleated sheet structure, right? Now this is the normal folded protein, and then we have a misfolded protein which says amyloid here, and then these form the sheets here, the beta sheets. These are the beta sheets here, right? And then they form the fibrils or the polypeptides. So I hope you understood the cartoon. Now this is another picture from Wikipedia, and you can clearly see the beta amyloid here with the beta conformational state, and they are placed in a sheet, right? It's not helix like alpha helix here, right? It's a sheet. So what are the general mechanisms of protein degradation? So you know that usually in our body we have alpha helical protein conformation, and to get rid of the proteins, or let's say for the process of protein degradation, we have two mechanisms in our body. First of them is for intracellular proteins, and to get rid of intracellular proteins we have something called proteosomes. Now proteosomes are basically present inside the cell, and they are protein degraders, right? And they use the process of polyubiquitination, and then they break down the proteins into small peptide fragments. This is what a proteasome does. The second type of proteins are extracellular proteins, and for them we have macrophages. The macrophages phagocytose the proteins, and then they basically degrade the proteins into smaller peptide fragments. Now in amyloidosis, both mechanisms that I mentioned right now, they fail, right? And fibrillar proteins accumulate outside the cell. Now why do these mechanisms fail? It's because we don't have the alpha helical conformation that we require, right? That the proteosomes and macrophage require. We have the beta conformation, right? Which is like foreign to us. Now what are the three common forms of amyloid proteins? Now first we have NAL type, then second we have an AA type, and then we have beta amyloid or A beta type. This is a very important slide, so you need to focus a bit here. Now the first type is amyloid light chain type. A stands for amyloid and L stands for light chain. Basically here we have light chains of immunoglobulins that are accumulating, that are misfolded and are depositing in the organs and tissues. So that is why L stands for light chain of the immunoglobulin. Mostly we have kappa and lambda light chains that deposit in the tissues. The second type is amyloid associated amyloid, and here we have proteins that are derived by the proteolysis of something called SAA. Now what is SAA? SAA is basically serum amyloid associated protein. SAA is an acute phase reactant. Now what is an acute phase reactant? Usually when you have inflammation, right, you have acute phase reactants such as what? Such as, let's say, C-reactive protein. You guys have heard about CRP. Similar to that, we have something called SAA, right? Now that is a acute phase reactant proteins. They usually shoot up in our blood when there is an inflammation. So, and also they both are synthesized in liver. Now the third is beta amyloid protein. Now this is from proteolysis of a transmembrane protein, which is called amyloid precursor protein. So I hope you understood the three forms. Now what is the pathogenesis of amyloidosis, right? Now this is a cartoon that explains everything in a nutshell. So let's go through it and understand. Now first type would be the formation of insoluble fibril, right? So picture number A shows that there is a native folded protein, and then there will be a misfolded protein, and monomers from that protein, right, or the polypeptides, they will intertwine together and form a structure called fibril, right? So I hope you understood this point. Now the second type to form the amyloid is basically production of abnormal amounts of protein. Now how do you produce abnormal amounts of protein? Yes, you guessed it right. I just told you in the last slide. You have basically accumulation of misfolded light chains of immunoglobulins, right? Now such a phenomenon is called a monoclonal B lymphocyte proliferation mutated, right? So after having acquired mutations due to some unfortunate incidents, you have a monoclonal B site proliferation, and that leads to the plasma cell formation, and then you have the mutated or misfolded immunoglobulin light chain, and because of not undergoing the process of proteolysis, we have the AL type protein, right? L stands for light chain. Now the next type is chronic inflammation. So you have, let's say, SAA protein, which is the acute phase reactant, and because of some process of chronic inflammation, the macrophage were activated. The macrophage secretes interleukin 1 and interleukin 6, right? And then in the liver, we have the production of SAA protein, and that SAA protein is produced in large amounts, and because of limited proteolysis by the proteosomes, it undergoes the formation of amyloid, and the protein is AA protein, right? So I hope you understood this point. Now the last type to form amyloid is production of normal amounts of mutant protein such as a transthyretin. Now transthyretin is basically a complex that carries the hormone thyroxine in your blood, right? So if there is inherited mutations in the transthyretin, right, that can form the amyloid, and they aggregate a lot, and then that causes the problem. So we have ATTR protein here. Now what are the types of amyloidosis? Now there are only two types of amyloidosis. First there is a systemic amyloidosis, then second there is localized amyloidosis. Now let's go through them. Now systemic is also called generalized amyloidosis. Now here we have two types: primary amyloidosis and secondary amyloidosis. Now in primary amyloidosis, we have systemic deposition of AL amyloid protein derived from immunoglobulin light chain, right? There are clonal proliferations of plasma cells that synthesize abnormal immunoglobulin molecules. Now this is associated with certain diseases, and the most common disease that you need to remember is the multiple myeloma and the other associated plasma dyscrasias. You have many plasma dyscrasias like MGUS, monoclonal gammopathy of undetermined significance. Then you have multiple myeloma, right? And you have many others. So remember, plasma cell dyscrasias are responsible for primary amyloidosis, specifically speaking AL amyloid protein, formation of AL amyloid protein. Delta light chains are 6 times more likely to deposit than the kappa light chain. Both of them are light chains of the immunoglobulins. Now let's talk about secondary amyloidosis. Now here we have systemic deposition of AA type amyloid derived from SA, which was the serum amyloid associated protein, right? Now this is an acute phase reactant, very high yield to know, that is synthesized by the liver in which conditions? chronic inflammatory conditions, and also in certain malignancies. Now, most frequently associated condition here is rheumatoid arthritis, right? And the SSA is synthesized by liver, and it is stimulated by certain cytokines secreted by the macrophages, which are interleukin 1 and interleukin 6. Now, the last type is the hemodialysis associated amyloidosis. Now, here patients on long-term hemodialysis, right, after chronic failure can develop amyloid deposits derived from a protein called beta microglobulin, beta 2 microglobulin. Now, kidney is the most common organ involved in amyloidosis. You have to remember this. If in any exam they ask you what is the most common organ to undergo amyloidosis, the answer is kidney. Amyloid deposits lead to nephrotic syndrome. I'll show you a picture in a minute. So I hope you understood the systemic amyloidosis and its 3 types, right? Now, let's go to localized amyloidosis. Now, here the amyloid deposits are localized to a single organ, right? They're not systemic. First is a senile cerebral amyloidosis. Here we have A beta amyloid deposits in brain which are forming amyloid plaques. So if individual with Down syndrome, right? Down syndrome is trisomy 21. If they have amyloids, especially A beta amyloid deposits, they are much more prone to develop Alzheimer's at an early onset of the age, which is by the age of 40 years. So I hope you understood this point. The next is isolated atrial amyloidosis. Here we have AANF amyloid protein, which is derived from atrial natriuretic factor, right? Atrial natriuretic factor is secreted by, as the name says, atrium, and it helps in, as the name says again, natriuresis, or throwing the sodium through the urine, right? Now, the next is non-insulin-dependent diabetes mellitus, which is type 2. Now, here we have amylin, which is derived from insulin, that deposits in the isolates of pancreas and causing problems there. Now, the last is basically medullary carcinoma of thyroid, and here we have calcitonin deposits within the tumor that act as the amyloid. Now, what are the types of amyloidosis? This was like one part of the amyloidosis that I talked about, right? So, the first one was what? Systemic or generalized amyloidosis. The second was localized amyloidosis, and the third and last type of amyloidosis is hereditary amyloidosis, right? Now here comes the transthyretin part that we did in the cartoon, right? The inherited mutation. So this is where it comes. So the first is familial Mediterranean fever, and this is basically autosomal recessive disease, and this is called the autoinflammatory syndrome, right? This is an autoinflammatory syndrome associated with excess production of cytokines interleukin 1, and it is this cytokine that is produced in response to an inflammatory stimuli, right? AA type amyloid is seen here. Let's go to systemic senile amyloidosis. So this is a type of autosomal dominant disease. Here we have an amyloid protein that is made up of mutated transthyretin, right? Transthyretin, I repeat, it is a molecule that helps to carry the hormone thyroxine in the bloodstream, right? And what are the causes for this type of amyloidosis? It's the senile cardiac amyloidosis and familial amyloidotic polyneuropathies, right? So if you have such a mutated transthyretin, now this amyloid will deposit in the heart, right? And it will cause problems. That is why it's senile cardiac amyloidosis. It can also deposit in certain nerves, and it can cause polyneuropathies. And why familial? Because obviously this disease is autosomal dominant, right? Now, how do you diagnose an amyloidosis, right? Diagnosis generally requires a tissue biopsy, right? And now comes the major important point. The most useful stain in the diagnosis of amyloid is Congo red. When you use a hematoxylin eosin stain or HE stain, usually it stains red, and it is very hard to differentiate the amyloid, which is red of course, with other hyaline proteins, right? So it's very hard to differentiate them because the hyaline proteins also stain red with HE stain, and the amyloid does the same. So to differentiate the amyloid from the other hyaline proteins, we use a stain that is called Congo red stain. Now Congo red stain, when you stain it, if you just look normally, it will be red, right? Just like HE stain. So how do you differentiate? You have to use a polarized light. So you take a slide, you have the tissue biopsy, you stain it with the Congo red stain, you put it in a polarized microscope, and then you see. So under the Polaroid microscope, the amyloid proteins will appear like a apple green deposits or apple green birefringence on microscope. So you have to remember that. So remember two things: Congo red stain you use to stain the amyloid, and then under the microscope you will see a apple green birefringence of the amyloids. Now let's see the picture here. Now this is a picture that shows the lymph node, and you can clearly see the amyloids post using the Congo red stain, and then you can see all the red amyloids here. If you have an amyloid deposition in the heart, right, now this red fluffy material that you see here, also here, these are all amyloids. So this causes cardiac amyloidosis, right? And this is how under a polarized light, right, an amyloid looks. So you can see the apple green birefringence here, right? Here's an amyloid, here is an amyloid. It's like an apple green. You have seen an apple, right? Green apples. So exactly like that. Okay, let's see the next slide here. Now this cartoon shows us a glomerulus, and this is a pathological glomerulus. Here we have the nephrotic syndrome, and here you can see these small crystal-like structures. These are amyloids, right? Remember always, kidney is the most common organ where we have amyloid deposition, right? Now what is the treatment? Treatment with high-dose melphalan. This is a new therapy. It's a chemotherapeutic agent which is followed by a stem cell transplantation, and they say that it is recommended for stage 1 and stage 2 AL type amyloidosis, so immunoglobulin like amyloidosis. If you have an AA amyloidosis, this one makes more sense. You have to give a drug that is called eprodisate, and it has been shown that it slows the renal impairment by inhibiting polymerization of amyloid fibrils. And the last is the ATTR. So if you have the amyloids that is formed by the liver, you can do a liver transplantation, and that therapy is very curative. Why? Because the mutated transthyretin which forms amyloid is produced in the liver, right? So this is the last slide. I hope you guys understood amyloidosis, something about amyloidosis. I guess now you know. I hope you guys enjoyed the video. If you like my video, then please subscribe to my channel. Please like the video, and thank you for your attention. If you have any questions, please drop your comments and I'll try to answer them. Thank you. Bye-bye.